Hello everyone, I'm Dr. Sudarshan, Assistant Professor in Department of Pediatrics. Today we are going to discuss about leptospirosis. So today we will be discussing etiology, epidemiology, pathology, clinical manifestations, diagnosis, treatment and prevention. So first introduction is this fever is also known as Canfield fever, canicola fever, hemorrhagic jaundice, mud fever, severe man's flu. It was first described by Adolf Weil in 1886. Leptospira icterohemorrhagiae was identified as a causative agent in pre-World War II outbreaks. So etiology-wise, it is a zoonotic infection. The species is aerobic motile spirochetes. Genus Leptospira. It is a thin helix-shaped spirochetes. There are 23 serotypes are there. 10 pathogenic Leptospira species are there with preferential host specificity. If you see the shape of this species, it looks like a question mark. And epidemiology-wise, it is worldwide in distribution. Most cases occur in tropical and subtropical countries. And habitat-wise, it will be in the warm and damp environment, water and moist soil. Humans are the accidental host and dead-end host. Population at risk are agriculture workers, veterinarians, abattoir workers, rod and control workers, sewer workers. And the transmission is by animal bites. Humans are barely reported. Pathogenesis, the Leptospira species, it enters into the broken skin or mucous membrane, it enters into the bloodstream, thereby organs. After enter into blood, it causes leptospiremia. It causes typical of influenza typhoid type of fever. And when it enters into organs, for lungs, it causes hemorrhagic pneumonitis followed by pulmonary hemorrhage. Liver, it causes hepatitis followed by ectohemorrhage. For kidney, it causes intestinal nephritis followed by renal failure. In brain, it causes meningitis and encephalitis followed by meningoencephalitis. And leptospira infection, it has two types of leptospirosis. Most commonly, it is asymptomatic or mild leptospirosis. In humans, it is most 90% of the cases. Mostly, it will be no or mild symptoms and no organ damage because of pro-inflammatory and anti-inflammatory response are strictly regulated. If the antibody response and pro-inflammatory response is more compared to anti-inflammatory response, then there will be a cytokine storm, then increasing leptospiremia, sepsis like phenotype, multi-organ failure, hemorrhage, death will be there in 5% cases. So severe leptospirosis occurs in 10% of cases. Clinical features wise, mostly asymptomatic, incubation period is 2 to 30 days. It ranges from asymptomatic infection to severe MODS. Anectic febrile illness will be there in 70% of the people. Aseptic meningitis in 20% of people. Severe leptospira in 5 to 10%. Illness can be monophasic or biphasic. Symptomatic infection may be icteric or anicteric. There are two phases are there, two types of leptospira, anecteric leptospirosis and icteric leptospirosis. In both the conditions, they have two phases like initial phase and later secondary phase. That is 2 to 7 days of initial phase will be there. It can be isolated from blood, CSF and body tissue followed by secondary stage. Second phase is immune phase or leptospiric phase. Disappearance of leptospira will be there from blood and CSF and it can be localized in the specific tissues with causing specific signs and symptoms. Appearance of IgM antibodies will be there. It can be persist in kidney, urine, aqueous humor in spite of circulating antibodies. During the immune phase, some children develop aseptic meningitis or uveitis, encephalitis, cranial palsy, paralysis, papilledema are rare. So normally anecteric leptospirosis, it starts as a prodrome, but in prodrome like fever with chills, lethargy, severe myalgia, bradycardia, low BP, lymphadenopathy, hepatosplenomegaly, conjunctival suffusion, orbital pain, photophobia. In 10% cases, transient rash will be there. Secondary phase, aseptic meningitis with recurrent fever will be there. CSF, increased pressure will be there. And unilateral or bilateral uveitis, which will be self-limited. CNS symptoms will be resolved within 1 week. usually no mortality. Icteric leptospirosis is the second type of leptospirosis. It is occurring only in most commonly in adults. Same septicemic phase, prodrome symptoms like fever, chills, all will be there, but immune phase will be different. Anictric may you will get aseptic meningitis with uveitis, but here Weil syndrome may you will get jaundice, acute renal dysfunction, thrombocytopenia, pulmonary hemorrhage, cardiovascular collapse will be there. Hepatomegaly increased, TSB increased, SGOT, SGPT will be there, proteinuria, hematuria, cast, azotemia, oliguria related to kidney will be there, abnormal ECG related to CVS, epistaxis, hemostaxis, pulmonary hemorrhage, GI hemorrhage will be there. Here it causes mortality is little bit higher, that is 5 to 10%. As we discussed before, anictric leptospirosis and icteric leptospirosis both have first stage and second stage. Both have first stage is common, that is prodromal symptoms. Second stage will be different. Second stage, meningitis, uveitis, rash, fever will be there in anictric. Jaundice, hemorrhage, renal failure, myocarditis will be there. Diagnosis wise, gold standard is microscopic agglutination test. There will be a four-fold increase in titers in paired sera is the diagnostic. Agglutinins appear after 12th day of illness. ELISA, latex agglutination, CFT also. There the tests are available with DNA PCR. Culture is from blood and CSF in the first 10 days. From the urine it is second week of illness. There are these growth culture medias like Fletcher, Stewart's, EMGH and Cortoff media. There is one stain called Wathin starry silvery stain. There you can identify the species. There are curvy in nature with question mark. Treatment is treatment before seventh day, it will decrease the clinical course and severity of illness. Treatment with penicillin G, cefotaxime, doxycycline should be initiated in suspected cases. So in patients with penicillin allergy, doxycycline can be used. Mild illness, you can use doxy, amoxiclav, and ampicillin. Severe cases, supportive care with special attention to cardiopulmonary status, renal function, and coagulopathy, fluid and electrolyte imbalance. Prevention is rod and control measure, avoidance of contaminated water and soil, immunization of livestock and domestic dogs, protective clothing for people with occupation exposure. Doxycycline can be given for the travelers to endemic area 200 mg once a week. The vaccine is difficult because of different of